Good evening, and welcome to Doctors on Call. I'm Dr. Paula Termuhlen, Regional Campus Dean at the University of Minnesota Medical School, Duluth Campus, and I'm your host for our program tonight on women's health and female cancers. Our panelists this evening include Dr. Melissa Robey, a family medicine physician with the Community Memorial Hospital Family Clinic in Cloquet, Dr. Sandy Stover, a family medicine physician and new faculty member at the University of Minnesota Medical School, Duluth Campus, and Dr. Colleen Evans, a gynecologic oncologist with Essentia Health. Our medical students answering the phones tonight are Anna Ayers-Luby of Waconia, Minnesota, Katrina Christian of Le Center, and Rebecca Fears of Hastings. The success of this program depends on you, the viewer, so please call in your questions on menopause, hormone replacement therapy, osteoporosis, breast issues including breast cancer, ovarian cancer, and any other concerns you might have on women's health, and we'll do our best to address them. The telephone numbers for your questions can be found at the bottom of your screen. And now, on to tonight's program. So, colleagues, it's Breast Cancer Awareness Month. It's October. And we've had so many changes in the recommendations for mammogram screening. I'm wondering if, Melissa, if you could maybe talk to us a little bit about what that looks like in your office.
Sure, yeah, absolutely. This is definitely a very common question that I get. There's a lot of confusion about what the guidelines are. And the problem is there are multiple guidelines that give different recommendations. So generally, when I'm talking to patients regarding this topic, we need to address their history and understanding where they're coming from. One of the most common guidelines I recommend to patients is the United States Screening and Preventive Task Force, which says start at age 50, do them every 10 years or every 2 years until you're 75.
Yep.
So most of the guidelines agree starting somewhere between 45 and 50 is the best place to do. The question again is, do you do it every year? Do you do it every other year? And again, I think that's really important to have that conversation with your doctor, depending on your particular risks, what makes sense.
Yeah, family history, we get a lot of questions about family history. So some of the viewers may or may not know that I also take care of breast cancer patients as a surgeon, and so we really do struggle with helping patients understand how to guide their family members. Yep. I think another place where we've had a lot of questions has been in cervical cancer screening. And so I'm wondering, Sandy, if you could talk to us a little bit about what that looks like in your practice.
Cervical cancer screening, and Dr. Evans should jump in too because she does a lot of that. But it used to be that we'd start screening in people's teenage years, and over the course of time, a lot of my mothers will remember getting their first PAP when they first became sexually active. But we have become to recognize that women do a really good job of taking care of their own internal health to a great degree. And so you don't start screening cervical cancer screening with a PAP until age 21. And what you do with those PAP results can vary from what it used to be up until about age 26, depending on what the HPV positive or negative result is, as well as what the PAP. And that's a little bit of a confusion for a lot of my patients, is what's a PAP, what's this HPV thing?
Explain that.
Yeah, the PAP is actually named after a guy, and I'm probably mispronouncing, but Papillonico, who developed the technique for looking at cells from the cervix on a slide. Wonderful advance up to that point in time. There was very little ability to screen. That was back, in the 60s, 70s? And that allows a pathologist to look at the cells to determine if they're starting to look abnormal, if they're starting to show signs of cancer. And there's different grades of that. That's also varied over the years in terms of exactly what term we use, but basically signs of increasing amount of change to the cervix. HPV is the human papillomavirus, and that has been, the ability to test regularly for that has been a huge boon to testing for cancer, I think. And so if the HPV is present, it doesn't mean you have cancer, but it means you do have a virus that can create enough activity in the area that it can be a risk for developing cancer. And so that's more, kind of falls into your bailiwick.
Sure, yeah. The human papillomavirus is the majority cause of all cervical cancer out there. And there are some very specific types that are tested for when you do a pap smear. And it's HPV 16 and 18 are the highest risk types, or we call them oncogenic, meaning that they're at risk for causing a cancer. So that's one of the things that we look for when we're determining how concerning is your pap smear, and we take in what the cells look like and the HPV status as well.
Well, one thing I know for women too is I talk with them about the HPV also being a virus that can cause problems in the perirectal area. There's some, it's not, the link isn't 100% clear, I think, but there's an increased risk of throat and esophageal cancer that may be linked to HPV.
Well, so we have a question from Emma in Duluth on the theme of cancer. And Colleen, I think maybe this might be a good question for you. The question is, why doesn't anyone talk about a change in menstruation as a symptom of possible ovarian cancer? So maybe just talking a little bit about ovarian cancer and what those symptoms might look like.
Sure. So ovarian cancer is one of those cancers out there that does not have a screening test. The signs and symptoms of ovarian cancer are incredibly subtle. It's typically bloating, potentially having no weight changes, but your pants not fitting quite right because of the bloating. It could be feeling full early, even when you eat a normal size meal when you wouldn't typically be full. It could be abnormal discharge that you're expecting or that you're experiencing from your vagina. It could be just an overall sense of fullness, change in your bowel and change in your bladder habits. Sometimes a change in menstruation can signal that there's something going on in the gynecologic tract, but it's not one of the common or hallmark symptoms of ovarian cancer. That is usually more related to an endometrial cancer or a cancer that arises in the lining of the uterus versus on the ovaries themselves.
Okay.
Granted, most changes in the menstrual cycle are not related to cancer,
Right,
and
correct.
there are many other things that can cause that we should think about as well.
I think that's one thing in menopause is though if you do have bleeding that comes and you're more than a year and a half or 2 years after your last menopausal menstrual period, that's a time to call your doctor to find out if that kind of bleeding is a normal process or is that something that could be a risk for endometrial cancer.
So we have a question from Sturgeon Lake asking about, is there a consequence to being on birth control until menopause? And if it works, can't they just keep doing it until menopause? So let's talk a little bit about birth control and sort of length of time on birth control, the influences that might have. Who wants to field that one?
You know, and then that's also one of those things that's had a changing target
Right.
in terms of what we've been telling people. And when I first started in practice 100 years ago, we would have women stop at 40. And the risk factors for being on birth control pills include, well, things that can happen with estrogen supplementation of any kind is issues of higher blood pressure, clotting issues. If you're a smoker, both of those things can increase. And so we do find other risks as women get older to be higher for those things. So adding ongoing estrogen can be an issue. It used to be we stopped at 40. Now that there's not a solid line. It depends on the conversation you have with your physician about your risk factors for clotting, for heart issues. Then making a determination around the time when you would normally have menopause, do you want to continue on any kind of hormone replacement or not? That's kind of what I talk with people about.
Yeah, and then about other options that do not contain estrogen as far as the IUDs and those sorts of things that people can use that tend to have a little bit better safety profile in the closer to menopause years. But.
Well, going back for a moment to talking about the HPV virus, we've got a question from Carlton that talks about what percentage of HPV turns into cervical cancer?
So that's a good question. HPV is a really common infection, and most people who have ever been sexually active have had an HPV infection. It doesn't mean that they have the one that is at high risk for causing a cervical cancer. Cervical screening with the Pap smear has a couple different grading systems that Sandy talked about just briefly, where you have mild changes, moderate changes, and then really severe changes. And we know those mild changes, the body can repair those cells and go back to looking like normal cells on the cervix. The more moderate and high-grade changes need to be managed surgically or very, very closely watched to make sure that they do not morph into a cancer.
Well, I think you touched on how many HPV viruses are out there and that there's a couple of I call them nasty actors. But people may be told that they have been exposed to someone with HPV, but it does not mean that they have the HPV that will lead to cancer.
And a lot of HPV infections, the immune system does actually take care of. So just because you were told when you were 21 that you have HPV doesn't mean that's going to continue for the rest of your life. So that's why that regular testing for women to see if the virus has cleared or not is important. The other thing I would mention is the Hpv vaccine. That is an excellent strategy for prevention of HPV. So that vaccine is recommended for all children starting at age 9. So both boys and girls. The time to do it is long before the initiation of sexual activity. activity. So it seems a lot of parents worry about, why do I want to give my young child this vaccine? That's really the time to do it. Not that we're thinking they're going to become active anytime after that, but even in the early, 10, 12 sort of years, getting that taken care of. They need less doses if we do it early. And the other thing I would mention is that there's a brand new approval from the FDA. So we've been given the vaccine just to people up to age 26. The FDA just approved it up to people age 45. So we're waiting for some more recommendations from the organizations that make those guidelines, so hopefully for insurance coverage reasons, but definitely a great idea.
I think it's worth pointing out that when kids do get it a little bit earlier, not only do they need less, but it does seem like it takes better. Yeah. So the earlier the immune system takes it in a way that makes it a more powerful punch to the HPV.
Yeah. Great. So Sandy from Duluth would like to know, what are some of the symptoms and causes of uterine cancer? Colleen?
Sure, yeah, that is absolutely something that is important. Uterine or endometrial cancer is the most common type of gynecologic cancer in the United States. The risk factors for it are never having had children, being overweight, being diabetic, having hypertension, and being postmenopausal. So like Dr. Stover talked about earlier, any bleeding you have after menopause really needs to be investigated because there is a much higher risk that it might be cancer. That being said, younger women can be diagnosed with endometrial or uterine cancer, and family history can play into this as well. There are some familial cancer syndromes that are genetically passed along from parents to children. Anybody who has a really strong family history of colon cancer that happens young before the age of 50, or anybody who has many women in their family who have had endometrial or uterine cancer that was diagnosed at a younger age before the age of 50, it's really important to talk to your doctor about that to see if there is a familial component to that.
So we've got a lot of conversation going on, a lot of interest right now coming in with our questions around cancer, and particularly around, back to the HPV for a moment, and cervical cancer screening. And so one of the questions out there is, why do we stop doing pap smears after 65?
And I'll take that one. The cervix is a part of the body that has an evolution to it, and so there's some changes that are natural, just as there are changes in your skin and your hair. The cervix becomes a little bit more sturdy, is one thing. Plus, your immune system will have been exposed over time and has a memory to it, and so that can help reduce the chance of any HPV becoming active. It does not mean that people over 65 are less sexually active by any means, but there is much less risk that the HPV will go on to develop anything that's problematic. And just for the LGBTQ community, it's still important, even if you have a same-sex partner, that you still get gynecologic exams, including a PAP. One of the HPV viruses can be one that can be on hands. It's not a common way, but it's a possible way. And there are definitely evidence of people who have not been penetration sexually active who passed HPV to each other.
And can men catch HPV from a female partner?
Mm-hmm.
Yeah,
yes,
and pass it on.
Which is why men should be vaccinated as well. It's not just a gynecologic cancer.
So back to continuing with this theme, though, of cancer in this region, are there risks of cancer from lichen sclerosis? Is it common that it turns into cancer?
Sure. Lichen sclerosis is a dermatologic or a skin condition that can happen on the vulva. Mm-hmm. And it typically happens in women who are postmenopausal, but certainly premenopausal women can experience it. It's typically a lot of itching or burning or a feeling of dryness. And over a very long period of time with untreated lichen sclerosis, it can morph into a cancer through that damage repair cycle where the skin becomes damaged and then repairs itself. There are effective treatments for this that can prevent lichen sclerosis from morphing into a cancer.
Okay. Pap smears again. Should they be continued after a hysterectomy?
I think the consensus from the SCCP is no.
If your cervix has been removed
Yep.
at the time of hysterectomy, you no longer have that part that causes trouble.
Okay. And I'm just going to add to that.
Mm-hmm.
If you had your hysterectomy because of changes on your cervix that were precancerous
Mm-hmm.
and associated with HPV, then it depends on the type of
Yep.
change, but there is a role for pap smears after hysterectomy if that was the reason you had your hysterectomy.
So another good reason
For
to
20 years after your cancer diagnosis and treatment, right?
Correct. Even a precancerous
Yep.
and in the cervical cancer population, yeah.
Okay. Well, let's shift gears and talk about something other than cancer for a few minutes. And so we have a caller from Proctor who talks about struggling with acne since high school and wondering what kind of birth control would be best to control acne and prevent pregnancy.
And this is a question, I mean, anything with birth control, it's a really good idea to talk with your regular physician because there may be birth control, but pills that can be helpful. There are a couple on the market that have a progesterone that does seem to help reduce the chance of acne. There are also a variety of other treatments that can help stabilize periods a little bit, and that can be helpful. But acne has a lot of things that play a role in developing cysts, and so topical treatment's still really helpful. There are some oral treatments that are helpful. But that's a question, I mean, I could give a couple brand names, but it's a question to work on, I think, with your regular doctor to develop a comfort level for what works best for you. Mm-hmm.
Well, okay, next question. Bev from Virginia wants to know, how effective is treatment for osteopenia, and what are the side effects?
That's an excellent question. I guess that would depend on what kind of treatment you're talking about. So it's my understanding that the guidelines say we shouldn't treat osteopenia with medications like bisphosphonates. That's most commonly Fosamax. So it's when you meet the diagnosis of osteoporosis that you would start considering a bisphosphonate medication. So if you're diagnosed with osteopenia, I think the best thing to do is regular weight-bearing exercise.
I was just going to suggest, yeah.
Trying to make sure you're getting enough calcium in your diet. There's a lot of controversy around the calcium supplements and which kind is best, but really what what the data shows most recently is dietary calcium is probably best, and then adequate vitamin D. So people in
there's
our
some
neck of the
controversy
woods,
there, too.
That's true. That's very true. But it's my understanding that in our neck of the woods we're mostly deficient. So that would be, if you're going to take any supplements, one to consider would be a vitamin D.
I think one thing with vitamin D that was being pushed for a while was to go with the higher dosages. So a normal vitamin D level, and we don't check that on a regular basis, but a normal range is right around 30 to 40. And for a while there was a thought to go up and push 40 to 50 or even up to 60 in women who had some risk for bone thinning. And that has been found to not actually be very helpful. And so an amount that's felt to be fairly safe is 800 to 1,000 micrograms, or international units, a day. And it varies a little bit, again, on your age or size. Talk to your doctor, to find a balance that works really well for you. But one thing, osteopenia itself is not a diagnosis. It's a range of bone density. Osteoporosis is a diagnosis. And so if someone tells you you have osteopenia, that is it's a point on a long continuum of a line, and you may stay right in that same range and not really have a greater risk for a fracture, which is the endpoint of osteoporosis. So it's important, again, to talk that over so you're clear with your physician what they meant with the term osteopenia.
Fair enough. So here's a question, and I'm not sure I'm going to get the drug correct, but a caller from Superior would like to know that a woman who's had a hysterectomy is taking Hemerin and is developing milk pockets in her breasts, and why might that occur? Does that sound familiar to anyone? Hemerin?
Unless they're taking an estrogen supplement for
maybe.
a while. Some women, after having
What were they taking it for?
A woman who's post-hysterectomy who's taking Hemerin to develop has developed milk pockets.
Maybe Premarin?
Could be Premarin, yeah.
Could be
Which is
Premarin.
a brand name for an estrogen product.
Yeah.
If people have had their ovaries removed as part of the hysterectomy, they were no longer producing estrogen from the ovaries. You do have some estrogen from other places in your body. And so for women who are premenopausal, there is a role for continuing estrogen and gradually allowing it to kind of mimic what would naturally decrease over time. With most women not being on estrogen replacement for more than 5 years or so. Women who've had a hysterectomy in their 20s may be on estrogen longer for the support for bones and other health.
Well, and I think on that theme, Colleen, speak a little bit about when someone has a hysterectomy, are the ovaries always removed?
That is a good question. So a hysterectomy really means removal of the uterus and typically the cervix. Removing of the ovaries is a different procedure, but oftentimes patients will describe it as having a partial hysterectomy, which I think that they usually mean just their uterus, or complete hysterectomy, which oftentimes means tubes and ovaries. So yeah, hysterectomy doesn't necessarily mean that tubes and ovaries come out. In women before the age of 65, the recommendation is if you have a hysterectomy for a benign reason, non-cancerous, that it should be considered to leave the ovaries in.
And is it okay to, is there a difference between leaving one ovary versus keeping both ovaries? Sometimes women have to have an ovary removed for a cyst or for some other reason, or in the course of another operation.
Sure. If both ovaries look normal at the time of the hysterectomy, then the recommendation is leave them both in. If one ovary is all that is left, that is plenty of hormones to make you go through a natural menopause and not go through an early menopause.
So for patients who are after menopause, now we're going back out of the cancer zone to talk a little bit about dryness in the vagina and its effect on sexual activity.
And that's a great question, and one I get a lot. I do have had a practice that's a little more patients my own age, frankly, more menopausal age. And so estrogen is one treatment. We were talking about Premarin, but and it does come in a cream form that can be used to help reactivate the cells that have become sort of estrogen starved. And that can help with lubrication and with flexibility of the tissue. And it can be it's a very, I think you're nodding too, so I think it's probably the single best, but there are other things you can do as well. So vaginal dryness is kind of multifactorial. It does help to increase moisture. It can be done at the time of intercourse with a lubricant. It can also, there are some vaginal moisturizers that are out there. Replens is one that or Vagisil is another, that can be used just like you'd use a moisturizer on skin to kind of keep it a little bit more supple. But I think most women can find, and again, bringing back to your regular physician who will know your situation, there's a balance with estrogen cream that can be used. It used to be, and there's a question kind of for you too, it used to be an absolute no-no. If you've had breast cancer or risk for breast cancer, no estrogen of any kind. And I know that there's been a softening of that for life, quality of life issues, that women aren't forbidden to use estrogen if there's been a cancer, a breast cancer, something like that.
Yeah, there are concerns about breast cancers that are responsive to hormones, specifically estrogen. Using that topical estrogen in the vagina is typically okay if it is a quality of life issue. There's not a lot of absorption within the bloodstream to go and activate any breast cancer cells. Similarly, women who have had a gynecologic cancer, there's many gynecologic cancers are receptive to hormones as well, and it's not an absolute no-no, but it is a conversation that needs to be had with your doctor.
So let's broaden this just a little bit to talk about hormone replacement therapy, another very common, popular topic. And when might women want to explore the utilization of hormone replacement therapy? How long might they be on? Just some general thoughts about that.
There was a wonderful study that is actually still ongoing called the Women's Health Initiative Study. And it did bring out some data that seemed really harsh. There was a doubling of cardiovascular risk in women who were on hormone replacement. And that's balanced against the fact that most women at the ages they were studying didn't have a high risk to start with. Doubling was important to understand. But estrogen itself does have some increased risk for some cardiovascular things, some clotting issues, again, high blood pressure. So the recommendation is to try to more mimic the natural amount of estrogen in the body around 5 years. At that point, it seemed like that was where the risk started to increase to a greater degree. I also am aware of some studies that if you have a number of years between when your estrogen stops naturally from menopause and then starting up more than a few years after you won't have as good a benefit as you will if you start the estrogen around the time where the significant side effects of hot flashes and things like that. There are other treatments for hot flashes, but estrogen is a valid one. It is a valid treatment for some people who are at high risk for bone issues. And again, that's a juggling act that you're best suited to talk with your regular doctor to help find that balance, what works for you.
Yeah, good. So one question that we've had is that, and we're going to be getting close to the end here, so I think it's important we're going to bring it back to, it's October, right? And it is that Breast Cancer Awareness Month. And so we've got a question here about women who don't appear to have any cancer risk. Should they decide to seek out a screening mammogram? And what if they don't? Because there's a lot of questions about radiation exposure and all of that. So I have to lead with a little part of this, which is to say that, Caucasian women in the United States, followed by African American women, have the highest incidence of breast cancer in the world. And we have some of the best screening tools here in the United States. And mammograms while we have a lot of confusion right now as to how many, how often, and when should we start, have really contributed to our ability to manage this disease and to really put it into a stage where it can be curable. And it's not true for every patient, but it certainly is there. So I would advocate that following the prevention and screening guidelines is the way to go.
I would agree. Again, following the most conservative guideline, which is to start at age 50 and do it every 2 years.
At minimum, yeah.
Yep.
Yeah. And I think so too. If there's a very strong family history, I think that might be something that would balance a little bit with people, a primary relative or more than one relative in the family and we didn't talk about it, but there are some other kinds of screening tests that can look at the genetics and the potential risk for an individual.
Right.
And sometimes even additional screening from mammograms alone to including breast MRIs for people who are particularly high risk.
Yep. Yep, agreed. So we have one last question here about what is the best option for long-acting contraception? Quick answer.
Depends on the age. IUD.
IUD. All right. Well, I have to say, I feel like I should apologize to our viewers because we have tons of questions. So thank you so much for your engagement tonight. I also really want to thank our panelists, Dr. Colleen Evans, Dr. Sandy Stover, and Dr. Melissa Robey, and our medical student volunteers, Anna Ayers-Luby, Katrina Christian, and Rebecca Fears. Next week, please join Dr. Paul Vollmer for a program on pain management and opioids, when his panelists will be Dr. Ifeyinwa Igwe and Dr. Timothy Kufal. Thank you for watching. Good night.